Dear students, today, dear students, today we will discuss about the drugs used in pregnancy and lactation. Okay, in this chapter, we will see how drugs can affect the pregnancy, how the drugs are categorized for use in pregnancy, and we will also discuss about pharmacotherapy of certain pregnancy related disorders. Okay, it's a small topic, so let's go ahead. We are all aware of the fact that pregnancy is 280 days period and it's divided into 3 trimesters. Okay. Now, 8 weeks post fertilization we call the structure as embryo, and during this period complete organogenesis occur, or most of the organogenesis occur except the central nervous system. Beyond 8 weeks we call the structure as fetus. As I already told, the entire period of pregnancy is divided into 3 trimesters, approximately of 3 months duration in each trimester. Now, what are the certain changes which occur during pregnancy affecting the pharmacokinetics of the drug? So, as you have already read in physiology, the physiologic changes begin in the first trimester and peak during the second trimester. Let's see what all the major changes which can affect the kinetics. For example, increase in plasma volume, increase in cardiac output, increase in glomerular filtration, increase in body fat, increase in hepatic perfusion, increase in estrogen and progesterone. All these things, if you analyze it properly, they will affect the various pharmacokinetic aspects of the drugs. For example, increase in plasma volume can affect the volume distribution, increase in cardiac output, glomerular filtration, hepatic perfusion can increase the elimination of the drug. Increase in body fat can cause an altered redistribution of drugs, especially lipid soluble drugs. And estrogen and progesterone can also alter the metabolism of certain drugs. And there is decrease in albumin and gastric motility. Okay, if the gastric motility is decreased, certain drugs will be absorbed more, and a decrease in albumin will cause free concentration of certain drugs to increase, which may lead to toxicity. Now, what drugs do to pregnancy? Of course, when we treat pregnancy related disorders, drugs are helpful, but most of the times they're not in pregnancy. Right? They can induce miscarriage, they can cause fetal death, they can cause congenital malformation, they can cause reduced fetal growth, then they can impair the function of the developing organs, they can reduce the uteroplacental blood flow, and they can even cause the increased risk of preterm delivery. And when drugs is secreted in the breast milk, it can cause side effects in the newborn. Okay, so these are the various things. So starting from the early pregnancy to postpartum period, we can see there are various effects which are caused in pregnancy due to drugs, and we need to take care of all these things before deciding whether a pharmacotherapy can be justified or not. We should always look into the risk benefit ratio. Okay, because no drugs is actually safe in pregnancy, but the benefits should outweigh the risk. When we talk about the transplacental drug transfer, because for the drugs to affect the fetus, they should actually cross this uteroplacental barrier, reach the fetus to produce its effects. Okay, so there are certain factors which can affect the drug transfer across plasma. First of all, lipid solubility. Okay. The more lipid soluble the drug is, they can easily cross the uteroplacental barrier. Then electrical charge. Of course, if there is more charge, they will not be able to cross the barrier easily. Molecular weight. As expected, drugs with lower molecular weight of less than 500 daltons can easily cross the uteroplacental barrier. Drugs with the molecular weight between 500 to 1000 daltons can cross the barrier in a restricted manner, and drugs greater than 1000 daltons can rarely cross. So this is one of the reasons why we always prefer the use of drugs with high molecular weight in pregnancy. Then degree of protein binding. If some drugs are bound to the protein more, then there will be very less amount of free drugs. Only free drugs can cross the uteroplacental barrier. Okay. And fetal pH. If you remember the physiology, fetal pH is a little acidic compared to the maternal plasma pH. So basic drugs can easily cross the uteroplacental barrier compared to the neutral and acidic drugs. Okay, right. But our drug selection during pregnancy, we need to answer certain questions before starting a drug during pregnancy. Okay, right. If we look into the baseline risk of congenital malformation in a population, 3 to 6% of pregnancies can have congenital malformation, and usually when there is some congenital malformation, most of the pregnancy gets aborted in the earlier days itself, such that even it can sync with the regular menstrual cycle. When we talk about the congenital malformations, malformations in the fetus or the babies, only 1% of the malformation are caused by the drugs externally administered, as compared against congenital malformations, which are actually 25% of the times the malformations are due to congenital. So basically what the epidemiological data suggests is, whatever the drugs which have been developed until now, they have been developed in such a manner that they had taken the issue of pregnancy into account, and until now the drugs have been proved to be relatively safe. But still, we cannot take risk while prescribing the drugs in pregnancy. Now, you should always remember that the organogenesis, most of the organogenesis gets completed by second trimester, that is 18 to 60 days. Okay, if you see that chart, see, most of the structures and organs are formed within the 2 trimesters, except the organs of the central nervous system or nervous system. So if we are giving the teratogenic drugs, teratogenic drugs means the drugs which can cause congenital malformations, not congenital malformation, the drugs which can cause malformations in the embryo or fetus. So if the teratogenic drugs are given during organogenesis, they can cause structural abnormality, whereas the teratogenic drugs given after organogenesis can cause either growth retardation or they can cause CNS abnormalities, as it is evident from the chart which was shown in the previous slide. So resources for determining certain the drug safety in pregnancy. Okay, it's very unethical to perform clinical trial on this aspect, so there is little clinical trial to evaluate the safety of drugs in pregnancy. It's all usually obtained from animal studies and observational studies, or from case series and reports, observational studies, case control or cohort studies, or even cross-sectional studies, or from animal studies. And this site motherrisk.org gives concise or good information regarding various drugs and their effects in pregnancy, whether they are harmful or whether they are safe. Okay. Risk categorization. Now, based upon the risk which the drugs pose to the developing fetus, they are classified into various categories. First, let us talk about category A. As expected, they are the safest. The drugs belong to the A are the safest. Okay. That means here there are actually controlled studies which has shown no risk. Or controlled studies in pregnant women have failed to demonstrate the risk of fetus in the first trimester with the no evidence of risk in later trimesters. So the possibility of fetal harm appears to be very remote. Example is levothyroxine and folic acid. Basically tells that there is an absolute evidence in human studies that it is safe. Okay. In category B, they are also safe, just that observational studies have shown no risk. Okay, or there are no studies in the pregnant women, but animal studies have not demonstrated a fetal risk. Okay, or animal studies have shown some fetal risk, but it has been contraindicated by human studies where it has been shown that the drug is relatively safe, usually in observational studies. For example, metformin, hydrochlorothiazide, cyclobenzaprine, amoxicillin, pantoprazole. And we have category C. Here the risk cannot be ruled out, but there might be situations where the risk benefit outweighs the risk, and these can be administered during the pregnancy. Here, animal studies have revealed some adverse effects on the fetus, and there are no control studies in women, or there are no studies in both animals and humans regarding the risk. So drugs should be given only if the potential benefits justify the potential risk to the fetus. Example, tramadol, gabapentin, amlodipine and trazodone. Category D, we need to be very careful because there are positive evidences of risk in the human beings. Okay, so there is a positive evidence of human fetal risk, but the benefits from use in pregnant women may be acceptable despite the risk. Especially it's used in life-threatening situation or for a serious disease for which safer drugs cannot be used or ineffective. Okay, example, lisinopril, alprazolam, losartan, clonazepam, lorazepam. Category X, completely contraindicated in pregnancy. The harm outweighs benefit far ahead. Okay, so studies in animals or human beings have demonstrated fetal abnormalities, or there is evidence of fetal risk based on human experience, or both. The risk clearly outweighs the benefit, as I told previously. So the drugs are essentially contraindicated in women who are pregnant or who are planning to become pregnant. For example, atorvastatin, simvastatin, warfarin, methotrexate, finasteride. When we talk about, as I told previously, when we talk about the decision making regarding the use of drugs in pregnancy, we need to answer certain questions. First of all, are the drugs necessary? What effects do these drugs have on fetus? What effect does maternal disease have on the fetus? What effect does pregnancy have on the disease? Okay. Only when we can answer all these questions to justify the use of drug, then we need to use the drug. Okay. For example, certain diseases which is not required to treat only, it can be just treated once the pregnancy is over. So those, it's better to continue the pregnancy during those times and then treat them accordingly, provided a safe drug is not available. If the safe drug is available, then we can treat. Okay, right. Now we will focus on certain pregnancy specific conditions and how to treat them. Example, nausea, vomiting. Nausea and vomiting is one of the most common symptom and signs of pregnancy, but it becomes troublesome when there is hyperemesis gravidarum, which accounts to 3% of the pregnancy. Usually it is treated with pyridoxine and newer antihistamines, not the older ones. And it has been shown that ondansetron is also relatively safe in nausea and vomiting. Gestational diabetes mellitus. As I told previously, we need to use the drugs of larger molecular weight. So any diabetes mellitus, we need to use only insulin in pregnant women. Okay. So it's usually present in 7% of the pregnancy. Diagnosed with oral glucose tolerance test, insulin is the drug of choice. Metformin can be given sometimes. Hypertensive disorders of pregnancy. Okay. Usually diastolic blood pressure greater than 90 millimeter mercury, then we call it as there is some hypertensive disorders of pregnancy. The risk factors are sometimes with pregnancy, what to say, if the pregnant woman was already hypertensive, then there is a risk of developing hypertensive disorders of pregnancy. Sometimes even normal women can just develop hypertension because of various factors, and we need to treat them. Okay, because hypertensive disorders can cause fetal growth retardation. Then there is preeclampsia, when there is increased, what to say, diastolic blood pressure along with organ failure, edema, and we need to what to say, take care of this condition very seriously. So it has been shown in certain studies that PERS-P, that is the women who have history of preeclampsia or family history of preeclampsia, it is better to provide certain supplemental calcium during the pregnancy period to prevent the incidence of, or to reduce the incidence of preeclampsia. Aspirin also has shown to be of a little benefit in preventing preeclampsia. When the hypertensive disorders are diagnosed, the first drug of choice is methyl-dopa. Especially it is very good in preventing the transition from hypertension to preeclampsia. And when there is preeclampsia, the drug of choice is magnesium sulfate, which can actually prevent the transition from preeclampsia to eclampsia. And there is gestational transient thyrotoxicosis and postpartum thyroiditis. Propranolol can be safely given, and after the inflammatory episode, there will be thyroxine deficiency, which can be treated with levothyroxine. During the thyroid storm, or during the elevated, during the stages where there is elevated thyroxine, it's better to treat the mother with propylthiouracil, okay, which is relatively safe compared to the other drugs. Pregnant women are more prone for thromboembolism. That's one of the physiological changes. And venous thromboembolism in pregnant women is increased by 5 to 10 folds over non-pregnant women, and the drug of choice is low molecular weight heparin here. Okay, because we should not use oral anticoagulants. Okay, they're very dangerous. Low molecular weight heparin, it's a very large molecule, and it will not cross the uteroplacental barrier and can be safely given. Asymptomatic bacteriuria in normal and or in non-pregnant women, it's not required to treat them unless they have other comorbidities. But asymptomatic bacteriuria in pregnant women has to be treated because the progression to pyelonephritis in pregnant women is more. the safest antibiotic is beta-lactam in pregnancy. Okay, so it's always better to treat the conditions with beta-lactam antibiotics in pregnancy, because sulfur containing antibiotics can cause kernicterus, fluoroquinolones can cause cartilage malformation, tetracyclines can interfere with the bone development, and being antimetabolites, trimethoprim can cause growth retardation. Tuberculosis in pregnancy. All the first line drugs are safe except streptomycin. Streptomycin, being an aminoglycoside, can cause various fetal abnormalities, can cause deafness and renal failure in fetus. Okay. Second line, when it comes to second line, we should try to avoid streptomycin, kanamycin, capreomycin, amikacin, and we should instead consider cycloserine, PAS, paraminosalicylic acid, ethionamide, fluoroquinolones. Regarding the usage of antimalarials, if chemoprophylaxis is required, chloroquine should be given for chloroquine sensitive malaria areas, and mefloquine should be given when there is a travel to chloroquine resistant malaria areas. If we talk about preventive treatment during pregnancy, where the malaria is endemic, it's better to give sulfadoxine and pyrimethamine. For treatment during first trimester, quinine and clindamycin for 7 days, and then with artemisinin combination therapy. In other trimesters, straight away go with artemisinin combination therapy. HIV in pregnancy. Many antiretrovirals are teratogenic, so we need to be careful while selecting the regimen. If HIV is detected after 14 weeks, before 14 weeks it is advisable to terminate pregnancy. After 14 weeks, if the CD4 count is greater than 350, the ARV prophylaxis combination should be TDF 3TC plus efavirenz. EFV is usually avoided in first trimester. If already on therapy, shift to nevirapine based regimen. And for the infants, we need to give nevirapine for first 6 weeks. Migraine, NSAIDs, no, it cannot be given. They can cause various problems, especially in the renal system in the fetus. Ergot, they are blood vessel constrictors, and they can reduce the entire overall blood flow to the fetus. Triptans are relatively safe and can be given in migraine. Epilepsy, carbamazepine and lamotrigine appear to be relatively safest. Other drugs are not safe. They are very well known to cause phenytoin, valproate. They can cause neural abnormalities, nerve tube defects. Issues in lactation. Not only during pregnancy but after the childbirth also, the child will be dependent on mother for the breast milk for at least 6 months, and the drugs can many drugs can cross the the lactating mammary glands, and they can mix up with the milk. Okay, so that factor should be considered while prescribing drugs. Of course, most of the drugs which are harmful in pregnancy can be given in a relatively safe manner during lactation, but still certain factors need to be considered. Drugs PK should, if the drug is very much lipophilic, they can easily cross the enter the gland and can be excreted in breast milk. Then what are the drug effects on lactation? Certain drugs which are acting on dopamine receptors can affect lactation, so it has to be carefully given during pregnancy. As I already discussed, how much is the drug excreted into the milk? Okay. All these issues should be taken care. And are there clinically significant pharmacodynamic effects on infants? So these things has to be considered before prescribing the drug to a lactating mother. If you look into the milk plasma ratio, for highly lipid soluble drugs it is understood that it's around 1. For highly protein bound drugs it is very much less than 1. For small molecules it is around 1. For weak acid and weak bases it is almost 1. For actively transported drugs it is greater than 1. So relative dosage which enters into infant, it's just a simple formula to calculate that. That is dosage via mother's milk by maternal dosage into 100. All are in per kg doses. So there is a weak correlation between the milk plasma ratio and the relative dosage. Okay, the milk plasma ratio is high. For example, say iodine, it's almost 15 to 65. So 49% of the given drug actually goes to the infant, which is not that good. Okay, otherwise if you see captopril, which is just milk plasma ratio 0.03, the relative dosage entering the milk is 0.014. But even though you can see that chlorthalidone milk plasma ratio 0.06, relative doses are 15% because there are other factors which comes into play when the drugs are, especially drugs with a longer half-life, eventually they will cross the barrier, enter the lactating mammary gland, and then they get excreted in the breast milk. So these issues should be considered while prescribing drugs to pregnant women. As I already said, no drug is safe in pregnancy until proven. So we need to take extra care while prescribing the pharmacotherapy for various disorders in pregnant women. We should see to that we prescribe only category A and B drugs, and if the benefits are clearly more, we can go for C drugs, and we should take further extra care to give D category drugs, and we should totally avoid category X drugs. Yeah, and you should also remember that drugs with larger molecular weight will not cross uteroplacental barrier. Classical example being heparin and insulin. Or any peptide or protein drugs, they will not cross the uteroplacental barrier and can be given in place of small molecules. So whenever large molecule drugs are there for a treating condition, it's always better to give larger molecules for pregnant women rather than smaller molecules. Thank you.